in terms of acute stroke management, the NIH Stroke Scale Score is an integral component of what we do when we assess stroke patients. And part of that is because so much of it is not only based on what are their deficits, but what people are eligible for screening for treatments and all those things are also based off of what their level of deficits are. The other thing that's nice about the NIH Stroke Scale Score is because of the training that people do for it and the certification that they do, it's pretty reliably reproduced among people performing it. There are a couple items that aren't so greatly reproduced, and I'm not going to touch on why as we go through it just a little bit. But overall, let me skip through here. Overall, this is one of those things where I tell patients when I'm doing it, this is probably the only test in your life that you want to score a 0 on, because it goes from 0 to 42 for your testing, and you only get points if you actually have something wrong with the testing. And so ideally, you want to score a 0 on everything. 42 is essentially dead, so you also really don't want to be a 42 either, because you can't do anything on the NIH Stroke Scale Score. And we look at it in terms of mild, moderate to severe. Those are a little bit antiquated and slightly outdated terminology that we use, but it does help us in terms of severity testing. The other thing that's useful about the NIH Stroke Scale Score is by repetitive testing, it allows us to see if people are changing. They're getting better or getting worse based on interventions that we're doing. And so that's one of the reasons why it's important. Once you get comfortable giving this and doing this, I've listed about 5 to 8 minutes. That's probably when you're about medium comfortable doing it, and you got to maybe stop and think and check your cards. If you're really comfortable doing it and you can do it off the top of your head, you can probably get it done in 3 minutes. And so that's one of the reasons why I bring that up in terms of the timing, is because there are certain instances where you may want to do this, and we'll get into that later about how that could be helpful, but you can get it done pretty quickly if you need to. There are inherent biases in the NIH Stroke Scale Score, and so I do want to touch on those a little bit because they're important. It is heavily biased towards language. Some of the things that you're asking people to do is either based on their comprehension of what you're asking them to do, or repeating to you. So can they speak? Can they describe a picture? Those sorts of things. And so you get more points. So if your left hemisphere, which controls the right side of your body, and your language is affected, you might score a 14. If your right hemisphere is affected on your motor and your sensory perception and your sense of where you are, even if it's the same location in the two sides and the same size of the stroke, you may score an 8. Based on the laterality of the symptoms. So just keep that in mind when people are talking about severity and some of the cutoffs. Is that's one bias in the NIH Stroke Scale Score, is it is biased towards having language deficits. The other thing that it's biased against is it really doesn't do a lot of testing for posterior circulation strokes. There's really only a couple of items in there that are testing for posterior circulation strokes. One of them is vision. The other one is what we call ataxia. If you guys are aware of the finger to nose testing, have you ever seen that done? So with the finger to nose, what you're looking for is, can they touch it well? And are they doing this? And if they're doing this, then that's ataxia, where they're consistently missing. They're trying and they're missing it. Not, and I'll show you, not great, but I'm okay. Not, I'm weak on this side, and now I'm trying to get my arm up to touch my finger. That's not ataxia, that's inability because you're weak to be able to do the testing. And so that's one of the biases, is you aren't going to score many points if you have a posterior circulation stroke, because your language may be fine, your motor may be fine, but it still could be a devastating stroke because you're not able to walk because your balance is so far off. And that's not tested at all in the NIH Stroke Scale Score. So that's another bias. All right, the gaze deviation, and this is another tip or trick if you're going to do this testing. So gaze deviation is typically a sign of severity in terms of you usually have to have a larger stroke happening for you to have gaze deviation. You will look toward the side of the affected brain. So if you have left-sided weakness, you'll have right-sided gaze deviation because it's the right side of your brain that's being affected because you cross sides. This can be hard to test if patients aren't able to follow commands. And so one of the things I teach my residents to do is that it is a reflex to track people's faces. And so if you have the patient up on the stretcher or in wherever they're sitting and you're trying to figure out if they have what's called forced gaze deviation, which is they can't track at all, or they have a gaze deviation but they can follow you and track past midline. If you get real close to them, see, nobody's sitting up front. So you get real close to them and you move your face back and forth from side to side in front of their face, they should automatically track you. And so if they can't track your face moving back and forth, then they have a forced gaze deviation. So that's one way to check as well for patients that can't interact with you to follow commands, because typically you're just saying follow my finger when you're trying to test for gaze deviation, but some patients can't do that, and so you want to see if you need to give them points or not. That's one way that you can do it, is by moving back and forth in front of their face. The facial palsy, when it's obvious, it's real obvious a lot of times, but sometimes it's very subtle if they have the facial palsy. And so you say to patients, show me your teeth, show me your, I used to always say, show me your teeth, but then I've had patients take their dentures out and hand them to me. And so, and I also stopped saying smile for me, because I've had patients say, why the hell do I want to smile? I'm having a bad day, I'm having a stroke, I'm having whatever. And so I just say, show me your gums, real big, show me your gums. And this is the obvious one, right? Clearly this patient has facial droop. This, and that's, they get the full score, that's a 2. This is the slightly more subtle one, where you look at them, you're like, yeah, you're a little softer on that side. The nasolabial fold's a little softer. They may be able, when they get real big, they may be able to overcome that slight asymmetry, but they still score a 1 for that. And then the really subtle ones, and the reason why I bring this up is because if you do choose to do the NIH Stroke Skill Score certification, I know this is on the test. And so I'm trying to give you a gimme on the test if you decide to take it, which is count the teeth on each side. If you're really trying to decide if they have a facial droop or not, you can count the teeth on the 2 sides. And so this guy, I don't know if he's having a stroke or not, but he actually has asymmetry, because you can see more teeth on the left side than you can on the right side when you get down to it to count them. And so that actually would be a 1 on the NIH Stroke Scale Score. In terms of the motor testing, I see a lot of our residents try to cheat, and they try to do 2 arms at the same time. That's really not the way you're supposed to do it. You're supposed to do 1 limb at a time. And part of the reason for this is because if there's something subtle there, you may miss it, because you're trying to look at two arms at the same time. They can't really ever, I've never seen anybody try to do 2 legs at the same time, but 2 arms at the same time. You want to put it at a 45-degree angle and let go. So either the arm or the leg goes to a 45-degree angle and let go. And then this is where you're going to get a lot of your points for motor testing. Of the 42 points, you can get 4 for your arm and 4 for your leg. On each limb is worth 4 points if they have no movement at all. So a lot of your potential points that you add up can be from motor alone. And so that's something to remember. You're supposed to do motor later in the testing, but oftentimes if I'm trying to make decisions about what I'm going to do for imaging or what I'm going to do in things, I'll actually start with a motor, because I know that those are my highest yield points potentially. So if I'm already hitting a 6, and that'll become more and more repetitive about why a 6 is important to us. If you hit a 6, then I'm like, we're already going for the next stage. And so I'll pick up the points later. If I'm just getting 1 point here and 1 point there, then I'll typically do the whole stroke scale score before I make the decision about where I'm going next. That's not me, right? Okay, good. So motor testing. Well, the trick with this is if you have them do it, and you say, I'll go over your arm, and you hold it up, and it goes thunk. The next step is, can you move at all? Can you move your shoulder at all? Can you do anything? Because that's going to give you the difference between a 3 and a 4 on your testing for the NIH Stroke Scale Score. Just going to show you the new, this is hot off the presses. This is actually the new picture. It's called the Precarious Painter. The prior pictures that we used for language testing were getting pretty outdated. It looked like a 1950s housewife doing dishes and some kids, and it wasn't particularly relevant, particularly for urban populations. And some people may have never seen a cactus that was in there. Some people may have never seen some of the things that were on there. And so they've revamped it now. And what you ask patients to do, and there are apps for this on the phone, and a lot of times people carry cards, but what you're asking patients to do is, tell me what you see in the picture when you do the testing. And you're looking for them to tell you kind of a story, because what you're doing is testing the fluidity of their speech and how much they can tell you and speak spontaneously, if you will. And so if someone says, oh, there's a guy trying to paint, he's falling off the ladder, and there's a dog that's got paint on the feet, and there's a car accident outside, like, cool, your language is fine, right? But if someone says, paint, I'm like, okay, is there more? Is there more there that you want to describe to me? And they may not be able to. The other thing that you want to look at is if they only describe the right side of the picture, they don't describe the left side of the picture at all, that can be a clue that they are neglecting. They're not paying attention. They either have a visual field deficit on the left, or they're not paying attention to the left side. And so I've had people go through the entire testing, and they only describe half of the picture, or they only say half the words. They like start in the middle of the sentences and read over. And I was like, does that not seem weird to you? Nope. They were doing what they were told to do. And then you have people tell you, it's bicycle, leaf, bridge, that sort of thing. Common pitfalls, and this is one of the things I talk to my residents about, is not testing all the items. I don't know why, but I often forget to do the visual field testing, which is part of it. And so especially when I first started doing it, I'd have to go back and check the points. I'm like, oh, I didn't do the visual field testing. Okay, I gotta go back and do it. So that's why having a checklist or an app on your phone or something to do it can be very helpful, because it reminds you. The ataxia that I mentioned, that again is a judgment call. So you always want to do motor testing before you do ataxia testing, because you have to decide if you think any trouble that they're having doing the finger to the nose or heel to shin is based on because they're weak or because they're discoordinated. And so that's sometimes I'll see, and this is a very common thing where people will give them extra points for the ataxia testing, because like, oh, they're having trouble with it. And so they give them the points. It's not that big a deal, but if you're trying to make decisions later about, do I drive an extra 30 minutes or not to get to a thrombectomy capable or comprehensive stroke center, you probably want to know that you're given the points that you should be giving to patients. And then inattention and neglect. Has anyone ever seen, and I do this sometimes, if I've got somebody who's come in and they're completely flaccid on the left side and they've got a forced gaze deviation, I'll just pick up their left hand and show it to them, and I'll say, whose hand is this? And they'll say, oh, that's your hand, or that's Mary's hand, or that's Joe's hand. Like, no, whose hand is this? And it doesn't matter what color the skin is. It doesn't matter, if they're wearing a bracelet or rings that they should normally recognize. They will not realize that that is their hand when you show it to them. And that's severe neglect that's happening there. And that's 2 points right there. And so again, you can know, okay, look, we're more than a 6 because I've got flaccid, I've got forced gaze deviation, and they're not even recognizing the left side. Well, let's go. And so that can be very helpful in testing. And this is what I was talking about with having patients just read. There's supposed to be a whole lot of other words on that side of the page, and they're not picking it up at all. So those can be other things to pick up on for inattention or neglect. I'm not going to do over the dizzy because Lauren will do that later. And then I already talked about, normally if you're training and when you do the certification, if you choose to do it, they make you do it in order. But the pragmatic approach is, as I said, I start with the high yield points. I typically start with motor and gaze deviation, and then sensory and neglect. And then if you do choose to get certified, there's a free certification available on the website. I think it's 3 or 4 hours of credit that you can get for going through the training and then getting certified. It's free to do it. You do have to set up a little quick account for it, but you don't get any spam or anything like that. So should you choose to pursue this, that's one way to get certified that doesn't come with any cost. And you can do it it's online, it's video. You can kind of do it as well at the training if you want to do it intermittently and go through and see it. So, and then I will afterwards. I have a tips and tricks page, a printout sheet that goes over a lot of what I talked about here that you can have with you while you're doing it, just to remind you how to do some of this stuff. So I have that for you. So that was a whirlwind tour of the NIH stroke scale score, as I said, because it sets up for the next couple lectures. But I'm going to stop there before I move on to the next set of lectures and see if anybody has any questions about what I covered.
Ma'am, in reference to the picture, do you find that certain letters, or I guess like a B for bridge, does that become difficult to say, like specific letters, or?
It can be, and that's where you have in the, I didn't really go over it here, but you're also listening to how the words sound, because not only will you get points for aphasia, so trouble speaking or trouble comprehending, but you'll get points for dysarthria, so how the speech sounds. And one of the ways that we test for that is there's a number of words that they have to repeat. I know these off the top of my head now. So it's mama, tip top, 50-50. And then I think the one that's the most challenging last one is baseball player. And so you can have them repeat that. You might already be picking up on some of it as they're listening. If I'm really struggling, I'll ask family sometime or someone else there, is this them? Is this how they speak? Versus some really subtle dysarthria. But so yes, through the picture, but then also with some of the additional phrases that you have them, it's how you can also pick up on how the speech sounds for testing. Anybody else? Yeah.
So how much do you run on this as far as efficacy of your treatments and stuff like that, and progression? Like,
Yeah.
looking more in like specific areas, or is it just global score?
So overall, historically, it's been the global score. And so looking at that in terms of severity, but that's actually a fantastic question because people are now looking at individual, what we call components. So like how does motor do over a period of time versus how does motor do if you also have neglect? Are there different patterns of recovery based on what kind of pattern of symptoms you have? And so there's a lot of research that's being done into that. It's not something that we do as standard of care right now. So typically it's the repeat NIH stroke skill score. So we use it to make decisions about eligibility for treatments. And whether or not we do advanced imaging on patients when they come in. And then we'll use it within the hospital stay to see if they're getting better or worse, because sometimes people will start to have swelling in their brain or they can have bleeding in their brain. And typically one of the ways that you'd pick up on that is if their symptoms are getting worse, then we get repeat imaging to see if they've developed any of that. So it's a repetitive score to keep track of how people are doing. But in some of the trials that I go over, they do use it for outcome, for testing of efficacy of treatment, plus something called the modified Rankin score, which I'll go over when we get to that. Yeah.
Is there a national standard on how often you do that repeat testing?
Yeah, so typically, so we have to document a baseline NIH stroke skill score. For comprehensive stroke center, you have to have that. And you have to have it prior to any treatment. So even if someone did one in an outside hospital and they were transferred in for a thrombectomy, we have to have one documented before they get the thrombectomy. And then we need to have one at 24 hours if we've done any kind of intervention on the patient. So whether that's thrombolytics or thrombectomy, they need to have a follow-up one that we have to document. Are there any additional, you would actually know better than I about other?
They're inpatient, so like say we get somebody from the thrombectomy suite, we're gonna do an NIH on them as soon as they kind of wake up from sedation because to kind of get a little more accurate. And then, like Dr. Heitch says, we'll do one 24 hours post-intervention. And then when they're ready to move out of our ICU onto the tele floor, we do a transfer NIH and then at discharge. And then the only other time that we'll do one right now is if there's a change in neurostatus. So, and then if there's like a change in neurostatus and their score goes up by 4 points or more, that's when we have to like call a neurologist, call a rapid response, things like that to determine is there something going on that needs to be evaluated.
So get shipped right back up and running CAT scan.
Yeah, you can anticipate at least a CAT scan to rule out hemorrhage because hemorrhage is going to be something that can happen with TI or TNK or mechanical nephrectomy. So.
Time is brain, and I spend a lot of time on QA and QI at our hospital with lots of other people. It's a whole team that looks at our process and how can we do things faster and how can we do things faster but safe and in a protocolized way. And part of the reason why we push time all the time and talk about time and talk about door to needle times and talk about door in and door out is because your brain is dying while that's happening. So for every minute of delay in treatment for patients who are eligible to be treated, you can lose almost 2 million neurons. So like 30 minutes, fifth grade's gone, right? Memories of something else is gone. You're no longer able to brush your teeth, those sorts of things. So as time passes, your area that's at risk for being permanently damaged gets smaller as your permanently damaged region gets bigger. And so that's one of the reasons why we push and harp and talk about time and doing things quickly and making decisions is because people's brains depend on it. And another way to look at that is this is over time, this is time at the bottom, and this is a number of studies that have been put together, but your chances of having a benefit from an intervention go down over time. And so as you, and this chart's got it, it's kind of small, but this chart's got it broken out into 30-minute chunks. And your number needed to treat is how many people do you need to treat for one person to have benefit from the intervention, the benefit being what you're testing for. So improvement in symptoms, significant improvement in symptoms, versus the potential to harm someone. And what you'll notice is that right here at 270 or 4.5 hours is exactly when it crosses the line, the lower confidence interval crosses the line between could you potentially benefit from this versus what are the risks of harming you if we give you this medication? And this is specifically for thrombolytics or TPA. And so That's why we push to try and get people to, symptom recognition in the population, quick activation, quick dispatch, quick transport, is because we know that we can help people a lot more if we can get to them early and treat them if they're eligible for thrombolytics or thrombectomy. And that's exactly that. So not only do we know that patients do better, but guidelines and monitoring is also based off of time. And so for comprehensive stroke centers, we are being held to this metric of more than 50% patients, at least 50% of our patients getting treated within 30 minutes of arrival. And that includes getting the handoff from EMS, getting the imaging, looking at contraindications, getting the medication mixed up, and giving the medication. And that goal is 30 minutes for thrombolytics. For thrombectomy, we want 50% of patients who are transfers to be having their first pass in the angio suite. So not only have they arrived, EMS handoff, getting your night stroke skill score done, making sure the team's there, getting them upstairs to the angio suite, getting access to the groin, and getting to the clot. That needs to happen in 60 minutes. And if you're starting in the ED, so if you're a scene into the ED, we have a little bit more time because we know we have to get the imaging and we have to make other decisions, so that's 90 minutes. But these are things that happen extremely fast. So that may be when you go bring a patient in to a facility, we're like, okay, what's the last known normal? What's the anti-stroke skill score? Because we know that we're trying to meet these metrics, and the reason why we're trying to meet the metrics is because we're trying to help people, and we're trying to get patients, more patients having benefit. I tell my residents, this is part of the lecture I give my residents, I call it where the magic happens, in the CT scanner, because our handoff is in the CT scanner. You'll have different, depending on what facility you go to, you'll have different ways that they do it. Ours is direct to CT if we think the patient's having a stroke, and the handoff happens in the CT scanner. We also recently, can you see this? I don't know how well, it's not gonna show. You see the clock, the really big clock in the left upper hand corner of the image, right here. So that is our clock. That gets started by our CT tech the minute the patient rolls in. And so that's even a bigger time pressure for us is 5 minutes have gone by, 10 minutes have gone by, 15 minutes have gone by. So there's a lot of pressure. But you also want to make sure that you're hitting all the things you're supposed to do and that you're appropriately taking care of patients and identifying patients who aren't eligible because you don't want to give the medications to patients who shouldn't be getting it. So one of the biggest things that I'm sure you get asked for is last known normal. What was last known normal? And we did a study actually at Barnes a few years back, so it was published in 2014, that actually looked at EMS reported last known normal times collected on scene versus the final determination by the stroke team and the neurologists, and how do they compare? And actually they were great. Outside of the specific situation with wake-up strokes, there was excellent congruence between what was reported from the field by EMS and what they'd acquired and what was the final gold standard actual determined last known normal. And so wake-up strokes are challenging. And one of the ways that I approach wake-up strokes is especially if a patient's coming in early in the morning, if I'm doing a day shift, and we get a, last known normal onset of symptoms was 6 a.m. Like, what time did you wake up? 6 a.m. Okay. Were the symptoms there when you woke up? Yeah. Okay. So now step back. What time did you go to bed last night? Went to bed at 11 p.m. Were you normal when you went to bed at 11 p.m.? Yes. Cool. Now I know what your last known normal was. And part of the reason why the last known normal is so important is that a lot of our, what we call treatment windows, are based off of what those last known normals are. And so that's why we ask is not only, and it's now become not only what was last known normal, but also ideally we're also asking when was discovery of symptoms, because there are things that we may be able to do for patients depending on when the symptoms were discovered. If they're wake up or if they live alone. Some of our older patients live alone and they may not have been seen by family for a day or two, and somebody went over to check on them and they found them at 5 p.m. and you're now bringing them in at 6 p.m. And so that can be very helpful for us to know, okay, it was 2 days ago was their last known normal, but symptom discovery was an hour ago, because that's another window that I'll get into that's helpful. Does anyone else have any tips or tricks for wake-up, how they differentiate between the wake-up strokes? No, same thing. The one thing I did start doing a while ago is I also ask if they're older, and often male, did you get up in the middle of the night to go to the bathroom? because they may have been normal when they went to bed at 11, but they may also have gotten up at 2 o'clock in the morning and went to the bathroom. And if the majority of their symptoms are motor symptoms, and they were able to walk to the bathroom and come back to the bathroom, chances are they were probably normal then at 2 a.m. It's got to be a little bit of a judgment call, but that may alter your window a little bit if they got up in the middle of the night and did something. So that's helpful. And one time I had a lawyer who came in, he was found in his office, completely aphasic, flaccid on the right side. And I was like, I know that he had to get to the office. So at some point he got to the office. And so we were able to work our way back from his schedule to figure out his last known normal time and get him treated instead of just saying, you don't qualify for anything because I have no idea when your last known normal time was. So it can be helpful. So as I mentioned, why do we focus on these things? So your eligibility for thrombolytics or for thrombectomy are based on those windows, your time from last known normal or onset of symptoms, your NIH stroke scale score, as well as then we get into advanced imaging. And so your CT angios, which is going to give you a look at your blood vessels in your brain with contrast, and then your CT perfusion, which is going to give you some idea of how well the blood is flowing through certain areas of your brain. I'll show you some examples of that. And then after that, we get into other things like medications. Are they on a medication that they can't get thrombolysis with? Are they on, do they just recently have major surgery? There's a lot of times with our own inpatient activations where patients don't qualify for anything because they just had open heart surgery or they just had some massive, cancer colon removal surgery. And I'm like, I'm just going to back away from that one because they're really not a candidate for that. And then as I had mentioned, we use the modified Rankin score to evaluate the impact of the interventions and studies. I'm going to give you just a quick overview of what that is so that when we're talking about outcomes and potential benefit, this is another one where you want to score 0. So this is the second scale in your life that you want to score 0 on. So it's 0 to 6. 0 is you have no symptoms at all left over from the stroke that you had. 6 is you're dead, which is why it's supposed to be black on there, but because the slide is black, it turned white. So 6 is dead. And then you have your intervals. So 1 is, I still have some symptoms, but they really don't affect my quality of life at all. So an example of that may be you have a little bit of facial droop left over, but you're still able to do the same job, you're still able to do everything else. So you wouldn't be a 0, but you're a 1. And then 2 and 3 start to get into some of the, can you walk, can you live by yourself, do you need somebody to come in and help you, those sorts of things. 5 is basically sniff. You are bedbound, you have to have someone who's constantly taking care of you. It's not really an ideal situation. And so we don't want to be, by doing interventions, we don't want to say, well, you're not dead, but you're a 5. And so, is that better, is that not better? There's some studies looking at that with patients and their family members about what their thoughts are on that. But really what you want to be doing is making a whole lot more people who end up in the 0 to 1 category or 0 to 2 category, as opposed to just pushing things up a little bit into the severe morbidity that's associated with it. Before I move on, since we're going to talk about this, does anyone have questions about the modified rank? Okay. This is not something that we do in routine practice, by the way, to follow up on your question. This is mainly used, well, I take that back. It does factor into the thrombectomy decision, but in terms of what we would be asking something to be done in the pre-hospital setting, we don't use the modified Rankin really at all. This is mainly used in research purposes to look for interventions. And then we do, for people that we give TPA or tenecteplase and do thrombectomy on, we do a follow-up 90-day. Every hospital does a phone call to the patient or their family member to find out how they're doing. And so this is something that we track for that purpose as well. So I contradicted myself. We do use it. We just don't use it in the acute setting. Don't use it in the acute setting. So to tell you about the windows, we kind of have to take a walk down history lane. And the reason why we have certain treatment windows is all based on research. And this is just a taste of all the research that's been done in terms of trying to figure out how best to take care of stroke patients. The ones in yellow are the ones, mostly the ones in yellow are the ones that I'm going to be highlighting and talking about over the next few minutes because they've really impacted our practice. But you can see there's a lot of other trials that were done that were either negative or showed that there wasn't benefit for doing different windows or different types of medications, because TPA was not the only one that was being tested for a very long time. Just Motoplace and other medications were being tested as well. So, this didn't turn out quite so well. That's okay. So in 1988, if you had a stroke or your family member had a stroke, you got brought to the emergency department. A head CT was done to look for hemorrhage, and we kind of said, that sucks. And like, put you over, wait for admission, get admitted to neurology, get your stroke symptoms worked up, get your risk factors worked up, and go from there. There really wasn't much at all that we could do for patients in 1988 to have any kind of impact on their long-term outcome acutely. And then in 1995, there was a publication in the New England Journal of Medicine, and actually where I trained in Cincinnati, there were people still practicing who had participated and enrolled patients in this trial. So it's not very long ago that our practice pattern changed and what we're doing, and things then, not as they started to change, they started changing really rapidly as we picked up speed. So in 1995, 2 trials were published together. So it was a part 1, part 2. They did them back to back. They did the same hospitals, and they enrolled patients. They did 624 patients, and they looked at IV TPA within 3 hours versus placebo, versus standard of care treatment, because that's what was the standard of care, was no treatment, essentially, other than blood pressure modification, trying to prevent secondary infections, all those kinds of things. And they looked at a number of outcome measures, but since the time that they looked at a number of outcome measures, the main one that we use over and over is the modified Rankin scale. And so what you can see is in placebo is the top bar and TPA is the second bar underneath that. And they've got it split up into 0 to 1 because the modified Rankin of 0 to 1 was the endpoint that they were looking for. And remember I said 0 to 1 is either no symptoms at all or symptoms. You may still have some residual symptoms, but they should have no impact on your life and how you are able to do your day-to-day activities, that you won't be able to go back and do all the things that you normally do. So pretty good outcome from that one. And they found that more patients who got TPA had a modified Rankin of 0 to 1 at 90 days than patients who didn't. And that was a difference of 39% versus 26% for the trial. And when you put that into, okay, what does that actually mean? Is that's the number needed to treat is 8 when you look at the difference. So essentially you need to give 8 people TPA who are eligible for it, who meet the criteria, for one person to get all the way back to a 0 to 1 at 90 days. And so when I'm talking to patients and their family members about getting thrombolysis, I tell them that it's an opportunity to get better. It's not a guarantee. So not everybody who gets it gets better, but more people who get treated get better than people who don't get treated with it. And so I kind of set patients up and their family members for that, because oftentimes you think, I'm getting something, a medication, I'm going to get better, right? I'm going to put on antibiotics. My infection should get cured. And so I just want them to know that this is the best thing that we've had for a long time, up until recently. And those are kind of the roll of the die, is that we know more people get it, who get better, who get it than don't. And this is a pictogram that was developed to look at that, and there are some risks associated with it. The red people at the bottom are the people who can have risks associated with getting TPA, and so the main risks are bleeding in the brain that can happen, and 6.4% of patients who got TPA had any kind of bleeding in the brain. 1 person out of the 100 can have death as a result of that, so that's the severe. But when you look at the 90-day outcome in terms of overall death rates, despite that, more people in the placebo group died by 90 days than patients in the TPA group. And so that led to, those results of these 2 trials led to TPA being FDA approved and getting used in practice in 1995. And so in 1998, then, so we're doing by 10-year chunks. In 1998, sorry, my slides are a little messed up with the change in the background. We now had something that we could do for people if they got to the hospital within 3 hours. So if you got to the hospital within 3 hours and you were eligible for TPA and you didn't have a head bleed on your CT, we gave it to you. And we hope that you benefited from it and you got admitted to the hospital. So then, actually in 1998, there was a trial called ECAS-3 that was published. And ECAS-3 was conducted in Europe, only in Europe, but all over Europe, where they looked at the 3 to 4.5 hour window. So they said, okay, we know 0 to 3 is good, there's benefit. Let's look if we can stretch that out, and is there still benefit out to 4.5 hours from giving treatment to patients. And once again, they looked at the modified Rankin of 0 to 1 at 90 days for that, and versus, again, placebo, because there was no alternative treatment to put it up against. So placebo with standard medical care versus TPA, and there was still benefit. So if you remember from the earlier slide, though, in this trial, so more people, right, got into the 0 to 1 with TPA than the placebo, but now you need 14 people to, so you treat, for every 14 people you treat, one person's going to get all the way back to 0 to 1. Now that doesn't mean other people aren't shifting along the scale and getting better, but if you're looking for that all the way back to normal, essentially, that's the number of people that you need to treat to get all the way there. So, okay, a lot of people thought this is great, this is good news. FDA didn't approve it actually out to 4.5-hour window. And part of the reason why is because the FDA has certain standards of what they need to have done to be able to prove it in the United States, one of which is they want to have studies done in the United States that involve patients in the United States to see if there's benefit. And so technically, TPA is not approved out to 4.5-hour window. However, based on this trial, based on a number of different trials that have come since then, it is standard of care across the United States that we treat out to 4.5 hours for patients who are arriving. Technically, only approved to 3 hours, but standard of care is to treat out to 4.5 hours based on the research and the data that's out there. Okay? Any questions about that? So now you've got 0 to 3 stretched to 0 to 4.5 hour for thrombolysis. And in 2008, so jump ahead another 10 years, we're chugging along, and up to 4.5 hours now, we can get people in, we get the non-con head CT, we see if they have a hemorrhage or not, we see if they're eligible, we give them TPA, and we admit them. Okay, great, we got something. And then, in 2015, I feel like all hell broke loose. But what happened was, in 2015, there were 5 trials that were published, all back to back to back to back, because what happened was there was one trial, Mr. Clean, that published and said there was benefit. And all the other trials that were ongoing at the time stopped and said, we need to check our data. And they checked their data and they said, yeah, there's benefit. And so at that point, they no longer had clinical equipoise, and they felt like they couldn't randomize patients who were eligible for thrombectomy to not go to thrombectomy. So you've got 5 trials. I still remember going to the International Stroke Conference in 2015, and study after study was presented, and then they got up and said, this is now standard of care. And I remember Peter Panagos and I walked out, and Peter's another EM neuro person, and we looked at each other, we said, because all the studies started in the emergency department, right? All the studies were, you're in the emergency department, you've got a large vessel occlusion, and you're randomized. And Peter and I thought, what are we doing in the pre-hospital setting? How do we get these patients, how do we know where to take them? And so there was a lot of time spent scrambling after that, trying to figure out exactly that. How do we know, how can we identify these in the field? How can we know where to transport people? So it was a little bit of the cart before the horse in some ways, but this was 2015. All of these got published. And so what is thrombectomy? If you haven't seen one, we hopefully will have someone here later that's going to allow you to work with some of the devices and play a little bit with a setup. But basically, what a thrombectomy is you go in, and historically it's been through the femoral artery, but now we have some people who are doing it through the radial artery, which is pretty cool. A little less invasive that they can go in through the radial artery. They go in, they snake the device all the way up into your brain, and depending on what device they use, they try to suck out the clot that's there. So either grab it, pull it, or just literally hook up a suction catheter to it, let it sit there for a minute or two, and then see if they've opened up the blood vessel. The caveat to some of that, though, is that those devices only get so small, right? You can only get so far into the blood vessel as your blood vessels get smaller and smaller, and so this is where this concept of a large vessel occlusion comes in, where we have to have something that's big enough that we can get to those little squiggles up there at the very top. They can't get into those. There's not a device yet that I'm aware of that can get all the way up there into those little squiggle areas, but they can get into the carotid, they can get into the middle cerebral artery, and they can get now even into the second branch of the middle cerebral artery called the M2, which is, it's debatable. Some people call those large vessel occlusions, some people call those medium vessel occlusions, so LVOs, MEVOs, doesn't really matter. But the concept is that devices are getting a little more sophisticated, and so practice can change a little bit. But that's what we're looking for when we do our CTA, is to identify a blood vessel, if there's an abrupt occlusion that is large enough that our interventionalists think that they can get in there and pull it out and restore blood flow. All right, so that's what it looks like. So all 5 of those trials were not exactly the same, because research is fun and everybody thinks that they have their idea of how exactly it should be done. And so there was a lot of overlap in the trials, but they weren't exactly the same. And so we had to kind of put them together, mash them up a little bit. The majority of them, though, looked at the 0 to 6 hour window. So now we did 0 to 3, 0 to 4.5, 0 to 6 hour window. And generally, they were studying IV TPA versus IV TPA plus thrombectomy. So the majority of these trials, look, in fact, 2 of them, you had to get TPA to be enrolled in the trial and then go for a thrombectomy. The other thing that they looked at is several of the studies used that NIH stroke scale score of 6. Remember I was talking about that when I was talking about the NIH stroke scale score. So you had to have at least a 6 in order to get the CTA done at all, to get the imaging obtained, because part of the reason for that is the sensitivity and specificity of the NIH stroke scale score. So the more severe your symptoms are, the more likely you are to have a larger area of the brain that's being affected because you have a blockage of a large vessel. And so that's why we're using the NIH stroke scale score as some of the cutoffs. Is you don't necessarily want to give everybody a CTA because there's cost, there's radiation associated with it. Some people have allergies to the dye, and so we're trying to pick people that we're going to screen that we think are the most likely to have one so that we can then go on and see if they're eligible for thrombectomy. And the majority of these studies, in fact, I think it's like 95% of the patients were in the anterior circulation. So once again, the poor posterior circulation, not only were they failed by the NIH stroke scale score, but they're not included in majority of these trials because they're a little bit of a different beast. They behave a little bit differently. The posterior part of your brain has a little bit different characteristics to it in terms of how it deals with ischemia. And so they picked patients that they thought were the most likely to benefit and started out there with these studies. So these are anterior circulations. Most of them were carotid and M1 occlusions, so the very, very large vessels that they're looking at. And they used different devices, so that was some of the heterogeneity that was in the trials. But, as I said, all of them showed benefit. So for the thrombectomy trials, they use a 0 to 2 modified Rankin out to 30 days or 90 days because these are much more severe strokes, right? So even though you had to get an NIH stroke scale score of 6 to enter, the median NIH stroke scale score for most of these patients was 17. So you're talking about pretty severe strokes. And so they said, chances are they're maybe not gonna do as great, even if they have a pretty good outcome. And so we're gonna give you a 0 to 2 as what we're looking for our 90-day. So all of these showed benefit. So the darker blue are the patients who got thrombectomy. The lighter blue are the patients who either got TPA alone or standard of care. And what that came out to, this is back to our number needed to treat, is somewhere between 4 to 7, depending on specific study characteristics for benefit. So if you can go and take patient for thrombectomy, particularly if they're eligible for thrombolytics plus thrombectomy, because one of the things that's nice is the thrombolytics can already start kind of breaking up the clot a little bit and get it working on the clot. And so when they go in to do the suction, they may be better able to suction that clot out or grab that clot if it's already starting to break up a little bit. It's thought to be part of the benefit. So now we're at the 0 to 6 hour window for patients who qualify. And so that's one window, and there's benefit to be had. So things got a little complicated in 2015 in terms of your decision tree, right? And not only did they get a little complicated, but now we also have like got to do this stuff really fast as well. So the 30 minutes or the 0 to 60 minutes. And so I've gotten now, so I have like a decision tree in my head that I go down this when I'm evaluating patients, but we have an algorithm that we have laminated and stuck it up in our CT scanner so that our residents can go back and refer to it, because this is not straightforward in terms of it. But these are why now we're asking for last known normal, what's their NIH stroke scale score, and then do they have an LVO, right? And this is in the 0 to 6 hour window. So, okay, we're figuring out what we need to do. We're kind of trucking along. 2016, we got it pretty much figured out. 2017, we got it pretty much figured out. And then 2018 happened. And in 2018, there were 3 more trials that were published that had a big impact on our care. And so both of these, these first 2 trials I'm going to show went out to 24 hours for thrombectomy. So if 0 to 6 is beneficial, what about up to 24 hours? Is there benefit to be had? And both of these trials, though, not only did you have to have the CT angio to make sure that you have a large vessel occlusion, but now things are getting more sophisticated and you have to have a CT perfusion scan that shows that there's some benefit to be had, right? So it's not all dead brain, because you don't want to take somebody to thrombectomy and we open up blood flow to an area that's already dead. Because you can actually cause a lot of problems. You can cause more bleeding, you can cause more swelling and those sorts of things. So we're using the perfusion as a little bit of a tissue clock, right? Do we still have time where there's brain in there that looks like if we go and open up that blood vessel, that's actually gonna do well and survive in that time period. And so the Dawn trial went from 6 to 24 hours, and the Diffuse trial went from 6 to 16 hours. And they had slightly different characteristics of who they enrolled and what they did. But as I said, they all used perfusion imaging. And so I'm going to show you, both of these studies use the Rapid software, but there are lots of different software programs out there now. There's Viz.ai, there's other ones in Europe. They're all different programs that can do this type of processing. And this happens immediately. So we get the CT perfusion, it takes about 5 minutes to get the perfusion scan from beginning to end. And then immediately the images are getting processed because what we're looking for is 2 different measures. One is your cerebral blood flow and the percent of cerebral blood flow in the area. And the other one is your, how long it takes to reach your maximum blood flow through that area of the brain, and that's in seconds. And what that looks like once it gets processed is you get this nice output that spits it out, and the magenta, it looks like magenta to me, I don't know if you guys are purple or whatever, but magenta on the left side is essentially what we say is, that's dead brain, right? Your cerebral blood flow is less than 30% through that area of the brain. So no matter what, even if we take you to thrombectomy, you're still gonna have that area of the brain that's gonna be affected. And then the area on the right side is at risk, sort of, because you have to subtract out the dead brain. So you can see there's overlap, right? There's overlap between them. So the neon green side is your Tmax greater than 6 seconds. So your time to flow, it's got sluggish flow through that area. But if you take out the core, the dead brain, what you're looking for is these mismatch areas. And for the purposes of the studies, they were looking for a 1.7 mismatch, right? So you got to have some brain in there that if we go back in and open up, it looks like it's going to benefit from. And so, for example, this is someone for a patient who likely wouldn't benefit and wouldn't have been taken to thrombectomy under the trials because there's no mismatch, right? The area of the dead brain is exactly the same as the area with the sluggish flow. And so why subject someone to a procedure who may not benefit from it? Unfortunately, she's 33 years old. So, yeah, it's still on there. But, and then another study that came out was called the wake-up stroke study. Because for years, when patients came in and they were wake-up strokes, we were still in 1988 territory, right? We're like, oh, that's too bad. Just gonna put you over in the corner again and get you admitted, because we really didn't know what the window was clearly. Because the problem was, you could have had your stroke at midnight, or you could have had your stroke 30 minutes before you woke up. And it was really hard to be able to tell. You can't tell on the head CT unless you see an obvious area that has a stroke in it, and then you know you're well outside the window. You should definitely not be giving those people if you're already seeing major changes on the head CT, you got to stop and take a step back and say, do we really have our last known normal accurate if we think it's within 4.5 hours? But what they did is pretty cool. They had a bunch of patients who got MRIs that they knew exactly what their time of onset was because it was witnessed. And so when they did these MRIs on the patients, they said, you know what? The DWI is positive. So there's some abnormality in the diffusion-weighted imaging and how the water and the glucose and everything is moving through the brain. But early on, there's no flare positivity. There's not dead brain there. And so what they figured out was that they could now use, again, as I mentioned, the tissue clock, so an imaging clock, to try to set for the brain who may be within 4.5 hours of their symptoms versus patients who weren't. And what this was set up for was the wake-up imaging protocol, where we can take patients for a hyperacute MRI. And so what people would need to know is that this is not your full, it takes an hour to an hour and a half to get the imaging acquisition. We are looking for DWI, flare, typically something called a GRE, because that can give us an idea if there's bleeding or something else. And really, that's pretty much it. Sometimes we might do imaging to look at the vessels, if that would be helpful. But typically, we're just getting a sequence that takes about 5 minutes to obtain, because we want to get patients treated with thrombolytics as quickly as possible if they qualify. The kicker with this study, though, and it's kind of bizarre, is that this is where the symptom discovery comes into play. So they have to be outside the typical window for thrombolytics. They have to be more than 4.5 hours past when their symptoms are found. But symptom discovery and being able to get your imaging and being able to treat them and figure out if they can be treated has to be within 4.5 hours of symptom discovery. So that's where now not only are we asking last known normal, but we may also be asking about symptom discovery, because that's going to affect whether or not you might be eligible for going down this protocol pathway. So which do you choose? Now you've got a bunch of different studies that look at going for thrombectomy versus going and getting an MRI versus and getting thrombolytics. So how do we choose? Because things are got a whole lot more complicated. I just went through this. So if you look at these head-to-head, and this is the median size of stroke volume. So, but what if you're looking for them, a lot of patients came in who could qualify for either study, right? So the median time that people were coming in looking at diffuse theory wake-up was around 10 hours, 11 hours from last known normal. However, your number needed to treat for benefit is much lower if we can figure out that you've got a large vessel occlusion and go for thrombectomy versus going, because 9's very similar, right, to what it was for the regular TPA trials. So that's on par. So number needed to treat down the wake-up protocol is 9. So then things got even more complicated, because what we do when patients come in is this. So we start you out and we say, what's your window, what's your last known normal, what's your onset, what's your NIH stroke scale score? And if someone has an NIH stroke scale score greater than 6 and they're within 24 hours, we're looking for the LVO first. Well, let me take that back. We're looking to see if they're TPA eligible first, but then also looking for the LVO. Because if they have a large vessel occlusion and they're eligible for thrombectomy, their potential to get better is much greater than if we go down the MRI wake-up stroke pathway. If they don't have an LVO, then we'll pivot and send them up for the MRI. So you can tell some of these have very long door to needle times. I think it's like we figured out that our best metric for if we're working really fast is we add on 45 minutes to our regular treatment time for door to needle because of just going to get the MRI. Because even though the MRI takes 5 minutes, you got to get the MRI screening form. The nurse has to get them ready, and we've got to get them upstairs, and we've got to get them, into the MRI thing and everything. So it takes a while to be able to do that. So that's one area where things have gotten even more complicated in terms of your decision making. But to break it down, every single patient's going to get a non-contrast head CT when they get in, if we're thinking they have a stroke, right? Because we want to see if they've got a hemorrhagic stroke. For thrombolytics, we're still working on the 0 to 4.5 hour window as standard of care. There are studies out there that are looking to expand that window, but we're not there yet. And then for thrombectomy screening, if you're looking for if you're within the 0 to 6 hour window, all you need is a CTA and looking at the LVO. And if it's there, you're gonna go if you're eligible for thrombectomy. There's a couple other things that come into play, and we'll get to those in the second part of this. But if you're in the 6 to 24 hour window, not only do you have a large vessel occlusion, but you're also getting CT perfusion because we want to see if you're within a time frame where you would have benefit. And then the wake-up protocol is if you don't really meet criteria for anything else and you woke up, but you can be treated within 4.5 hours. So we have to make sure that there's no point in sending someone up for the MRI to get it done if they're not eligible for thrombolytics. So we make sure from the very beginning that they don't have a contraindication before we send them up for that, because that is a requirement of the protocol. So that was the whirlwind history tour of why we do what we do. So I'm going to stop there because maybe you have questions. I'm kind of hoping you do have questions. Otherwise, I may have gone through it too fast. I hope I hadn't. But yes.
So, say you're treating hypertension alongside of this as well, right?
Yep.
You can maybe see a change in some of the symptoms. How do you guys account for that? Is that something?
We do. So I'll give you an example. A lot of transfer patients. So there are patients who will recanalize with thrombolytics alone. So say we have somebody at Belleville, right? So we have someone in Belleville. They come in. They have an NIH stroke scale score of 15. They are within 4.5 hours. They don't have any contraindications. So they get TPA started. They get a CTA, and they've got an M1 occlusion. So proximal occlusion, cool. They get on the phone, they call our doctor's access line, they get received, our interventionalists say, we looked at the imaging, yep, we'll take them, send them. They send them. Boop. Ideally, that happens really fast. Sometimes it takes an hour and a half. So when they get to our ED, we look at them and we're like, hey, your night stroke skill score is a 3 now. They're probably not going to go to thrombectomy because chances are they've recanalized that area, and so there's no longer going to be a benefit for going to thrombectomy. So those are areas where that will change. The other thing, we're jumping a little bit ahead, but that's okay. The other thing is that with the TPA trials, there were some initial exclusion criteria which talked about rapidly improving symptoms. And one of the things that they kept that in is because they didn't want to treat a bunch of TIAs. Well, they didn't want to enroll a bunch of TIAs into the protocol. But the rule of thumb that we should have guide us in our decision treatment is you treat what's in front of you. So if somebody was initially a 15 and they don't have an LVO and they've gotten better to an 8, they're getting rapidly better, but they're still an 8. And so they would still be eligible. So there are different scenarios where changes in your symptoms can affect what you're eligible for. We've had patients before who have come in where they may or may not get a CTA if they improve very quickly. Typically, we'll go ahead and get a CTA just to see if there's something. Sometimes patients have really good collaterals, and that can kind of change the picture a little bit of what we're seeing, even though they have an LVO. So yes, things can definitely change, and so that's where it comes into play a little bit with the question earlier about doing the serial NIH stroke scale scores. So things can rapidly change depending on what patients' deficits are. Yeah.
So pre-hospital setting, we give labetalol to get the pressure down. Does that affect this? Is what you're?
It can shorten our door to needle times for sure. Because that is, I don't have it in this slide deck, but based on our ongoing QI/QA, treating blood pressure is our #1 year in, year out cause for delay in our door to needle times. In part because I think our ED team, especially our resident physicians, are so honed in on, does this patient qualify for TPA? Do I need to get a CTA? Do I need to do this? That they forget to look and see what the blood pressure is. And by the time they're like, yes, let's give TPA, like, oh, their blood pressure is 220, right? And so then you've got the mad scramble to, we got to start labetalol, we got to start nicardipine. And so if some of that treatment started in the pre-hospital setting, it could definitely potentially shorten our door to needle times on the inpatient, on the ED side.
What is the goal blood pressure for like TPA or thrombectomy?
So thrombectomy doesn't actually have a goal. There was no blood pressure within the studies, although there's been post-study evaluations of what we need to do with blood pressure, but that's still kind of a moving target. For thrombolysis, you want to have your systolic less than 185, and your diastolic, it's 110. 110, yeah. Because typically the problem is the systolic, not the diastolic, but sometimes it happens as the diastolic. And so one of the things that we're doing with blood pressure is we're working on, one of our goals for this year is to get a specific protocol in place of how to treat it, because the other problem that we do with blood pressure is we know in the ED we'll give 10 out of 20 of labetalol and then we'll walk away and do something else. And so instead of rechecking the blood pressure in 5 minutes, we're rechecking the blood pressure 15 to 20 minutes later, and then we've lost 15 minutes. Same thing with titrating your nicardipine. We could actually titrate it every 5 minutes, but it's not getting titrated that fast. And so we're working on some in situ simulations and training series to try and get more protocolized and better approach to getting blood pressure under control. Because you're absolutely right, that is one factor that consistently affects our door to needle time. Dan?
Yeah, and I just want to make sure that we understand what you're saying. You don't want us pushing labetalol out of the field for a single blood pressure reading. Is that correct? Or do you want us to do 2? You haven't written the protocol yet, I understand, but when you do, it's going to be based on a series of blood pressure. That's what you plan to do?
For the ED? Oh, for pre-hospital. That is in, I think that's in the works, right? If their blood pressure is on the borderline, right, so if it's 188, I'd leave them alone. Because you don't want to bottom somebody's pressure out.
I'm talking more like we're talking hypertensive crisis. We got
Give it. I mean, if you're allowed to give it, give it.
220 or something.
Yeah, because here's, yeah. So, yeah.
3 consistent vital signs. We got consistent. We're in hypertensive crisis. We got stroke going on. I'm going to go ahead and give some labetalol.
So
You keep vitals 5 minutes apart,
Yeah.
then you give it if it's
So-
above
a part of the reason in the past historically, you can tell I love history, was that they didn't necessarily want people to start treatment in the field because you hadn't yet differentiated between a hemorrhagic stroke and an ischemic stroke, and there were some current concerns that you could make them worse, right, if you dealt with their blood pressure, if they have a hemorrhage. But there's studies, I don't touch them on here, but there's studies that have been shown that there's not necessarily a benefit to acutely lowering blood pressure with a hemorrhagic stroke, but there's not harm. And so if you're not going to harm the patient and you may potentially help them if they have an ischemic stroke, then there's benefit to be doing it in the field. And so that's one of the reasons why we're moving to treating in the pre-hospital setting.
Delay what, when I get there, what you guys are gonna be doing.
Nope, no, it would not affect, honestly, it would, unless you bottom somebody's pressure out, which I highly doubt would happen in the setting with the protocol and everything, it's only going to help to start working on the blood pressure before you get to the ED. Because it will, if they have some on board, then that can give us a little bit of time to get a nicardipine drip started if they do have a hemorrhage, or to maybe give them another medication. But definitely let us know if you've had to treat them in the field, because what can happen is, especially if you're doing IV pushes, is you can start to get this happening with the blood pressure. And this is really bad in the setting of giving thrombolytics, because you can increase somebody's risk of having hemorrhagic conversion if they're doing this. So if I know that you had to treat somebody in the field, I'm probably going to be ordering a nicardipine drip from the get-go so that I can have a more stable control of their blood pressure, so that we're not having the ups and downs and rebounds post when the medication wears off. I like nicardipine. It's actually really hard. I mean, occasionally we've bottomed people out with nicardipine, but you don't see it very often. I hate hydralazine because you can get into dose stacking with hydralazine, where you don't see an effect, and all of a sudden you see a really big effect. And that's one of the reasons why hydralazine's actually been pulled off of the list of medications that's recommended in the guidelines to be used to treat for blood pressure. In the break, I had a couple of questions and a request from Dr. Tan to touch on some things. So one of them is a clarification. I know that I kind of wrapped everything up into a 0 to 4.5 window. So technically, there are slightly different inclusion criteria between the 0 to 3 and 3 to 4.5 hour window, because once again, the study was designed slightly differently. And so one of the ones in the 3 to 4.5 hour window is age. I think it was a 89-year-old cutoff. We've now essentially, in our practice and our standard of care, have just shoved them all together and essentially use all the same criteria between the 0 to 4.5 hour window. You may occasionally meet a neurologist or a stroke team person who is more of a stickler for that. And so they may rule them in or out, because technically that still exists. But in general practice, we just use the whole same set of criteria for the 0 to 4.5 hour window. Does that answer your question? Okay. And then the other thing was the NIH Stroke Scale Score testing is for the CTA. We do not use we do not rely on the NIH Stroke Scale Score cutoff if we think they may be having a posterior stroke symptom. Because of the biases that I touched on with the NIH Stroke Scale Score, they may only score a 2 or a 3 and not be able to walk. And so we often will still get a CTA on those folks because we're concerned about the posterior circulation. So that kind of throws a wrench into it. But in general, we're looking for the NIH Stroke Scale Score cutoff of 6 when we're looking at obtaining the CTA, CTP, and going on from there. There were some other questions, but we're actually going to get to those with a future slide deck. So I'm going to move on, because I do want to hit the tenecteplase. Yeah.
I just want to add, again, that the people in this room, I really view as clinical leadership out on the road. So I really want you to then help your colleagues out on the road make some of these difficult decisions when they have a bad stroke patient about where to go and how to treat them. So especially the NIH stroke scale, I really, Dr. Hyde is going to, in the next hour or so, kind of explain why that's so important for you to know as a critical care group. So I really would love it if all of you decided to get certified in NIH. It's free, takes a little bit of time, but man, it's going to help you decide a lot more, I think, on
Where to go. Yeah. And we are definitely touching on that in one of our slide decks. A couple things I wanted to mention quickly was I've spent a lot of time talking about the NIH Stroke Scale Score and cutoffs and this and that and the other. And in the past, we used the NIH Stroke Scale Score as a measure of what we called mild, moderate, severe. And when I was doing my fellowship training, we often didn't treat patients who were less than a 5, because we were like, oh, you've got a mild stroke, you'll be fine, right? However, about 30% of those patients over and over again in registries and studies don't go home from the hospital. They end up having to go to physical therapy or rehab or something where they're still having a significant amount of disability or morbidity from their stroke scale score. And so when it comes to treatment decisions, not only do we take the overall score into mind, but we may take things like profession may come into account. So if you're a commercial truck driver, if you have any visual issues, you lose your license. And so just having some visual field deficits may be a reason to treat with a patient if they feel like this would significantly affect their life. If you have a professional musician, concert pianist, violinist, and they have a one weakness in their arm, but they're like, I can't do my career if I'm not 100% functional, that's where some of these risk versus benefit discussions come into play with patients. So the ones who are flaccid on one side and not speaking are, in my mind, a slam dunk, right? The likelihood of them having a benefit is so much greater than the downside of giving it, but sometimes we take a step back with patients in the emergency department and talk about what would these symptoms mean for you if you didn't get better from them, and how much does that factor in your treatment decision making? So that's where that level of disability comes into play. The other place where decisions about your functional status, which I did touch on a little bit before, but for the thrombectomy trials, the majority of patients who got enrolled in those were highly functional people at baseline. So they came from home, they were working, they did those sorts of things. If you have someone who is bedbound at a nursing home, they were not enrolled in those trials. And so the benefit for those patients is not particularly clear, particularly if they were already bedbound. You have a stroke, what are you trying to get them back to in terms of their level of deficit? And so that's one of the things that goes into our decision making and discussion with the interventionalists is what was their functional status at baseline. So there is a chance that we may be asking you or your paramedics when you bring a patient is where do they come from? Do they come from home? Do they come from a nursing home? Do you have any idea? Do they use a walker or those sorts of things to try and see if they're potentially eligible for some of these interventions that we have?
Where are the facilities, where are they leaning towards right now? I've noticed with Barnes and several others, they're going for the TNK over the TPA.
For the tenecteplase? So this has become a shift across the country, and I'm going to tell you why fairly quickly. So thank you. So tenecteplase is a cousin of TPA. It is a genetically modified TPA where they made a couple of modifications to the structure that are beneficial. So one modification they made gives it a longer half-life. And so you no longer have to do a bolus and a drip like you do with alteplase, with TPA. It's just a bolus. And the reason why it's just a bolus is because it hangs around in your system longer before it gets broken down than TPA does. And that's because it got slightly modified so that the protein that normally breaks it down can't break it down as easily. The other thing that it got modified for is where is it? Well, I guess it's not in there. The blood-brain barrier. It doesn't have as much effect on the blood-brain barrier, which can lead to less risk of having hemorrhagic conversion later on with it being treated. And so based on the fact that it may be safer and it actually has some really appealing characteristics, particularly for drip and chips, right? That you don't have to mess with the tubing and you don't have to try and figure out, make sure they didn't get a higher dose than they were supposed to get because they're coming with a whole bottle and you don't know if they pulled out from the bottle before they, attached it and hung it. And so sometimes there's questions about, did they get the dose they were supposed to get? It's a bolus, which is super nice. It's still weight-based, so we still do weight-based up to 25 milligrams. But all it has to do is a bolus, and it's actually much quicker and easier to prepare. If you've done it several times, it can be 2 to 5 minutes, probably more on the 2-minute side to be able to prepare it and mix it. So it's a little bit also nice from that standard. There were actually a number of trials. So remember that timeline I showed you guys earlier with all those different trials that were up there? There were, as you went along, there were a number of trials looking at tenecteplase at the same time. And looking at tenecteplase maybe with thrombectomy, and looking at tenecteplase at different doses, and for a while we got into this really weird situation where based on some of the trials, if you were a large vessel occlusion, you actually got a slightly lower dose than if you weren't a large vessel occlusion, which didn't really make a whole lot of sense, but that's trying to mash up the different studies that had been done. And so there was still a lot of question about tenecteplase. And so based on the evidence from TPA, we were sticking with TPA. for a long time. But then as things started to come together, they finally did a large head-to-head trial between TPA and TNK, tenecteplase. They did it in Canada, but it was, I mean, they had 1,500 subjects that they were looking at. And what the design for this trial was what's called a non-inferiority trial. So as opposed to TPA versus placebo, where you had to say it's clearly better, giving the drug is clearly better, what they were aiming to show in this study is it as beneficial, so is tenecteplase as beneficial as TPA, which is called a non-inferiority trial. So it's not worse to give tenecteplase in someone than to give TPA. And by the way, we only have to give a bolus, and it's kind of easier to give, and so maybe that'd be a reason to switch over, right? If it's just as good, and that's where the non-inferiority trial, and the reason why I bring up the non-inferiority is because your statistics and your analysis are a little bit different in the way that you interpret the study. So this study looked at 0 to 4.5 hours, so they did the 4.5 hour window, and they did head-to-head randomized controlled trial of tenecteplase, and that's the 0.25 milligrams per kilogram versus the standard dose that you guys are familiar with, the alteplase, so the 0.9 with the 10% bolus and then the drip after that. And it included a wide range of strokes. So they had the mild, moderate to severe, so the NIH stroke scale scores, and they were pretty nicely weighted, where it's kind of like a 30%, 30%, 30%. So it was a good distribution of stroke severities. And just as we looked at with the other trials, you looked at the 90-day outcome and looking for that 0 to 1 modified Rankin. So totally back to normal or almost back to normal, where it doesn't really matter anymore. And what they found was that tenecteplase for the 0 to 1 did slightly better than TPA in the study. And so it met that threshold for being non-inferior. It didn't meet a statistical threshold, which is a secondary analysis. It's not superior to TPA, but it's non-inferior and probably slightly, maybe a little bit better. We know from some of the studies that were done in Australia that you're actually more likely to recanalize during transport as a drip and ship for large vessel occlusion with tenecteplase than you are with TPA. There was definitely a significantly higher percentage of people that did that. But in terms of all comers, when you do all comers who qualify for thrombolysis and you give them tenecteplase versus TPA, they do just as well. And so based on that, that's where the shift has come in. Now, not FDA approved though, right? At least not yet. So currently, tenecteplase is FDA approved for STEMIs with a delay or not available angio suite, but it's not FDA approved for treating acute stroke. However, based on this, based on the ease of use and the fact that you give a bolus, it's so much nicer for our patients that we're sending up for MRIs potentially or other things to just give the bolus and go. Like we don't have to deal with the MRI tubing, we don't have to deal with any of those things. And so that's where the switchover happened for hospitals. So BJC system-wide switched over in February of 2023. And we've been using it since that time. We have TPA as a backup just in case. Right, so you can still use TPA. It's not wrong for places to use TPA, but a lot of people have gone to tenecteplase because ease of use. And it has been slightly less expensive. I don't know if it's going to continue to be that way, but it's actually the same company that makes both, so who knows? And then we haven't looked at our data, I don't think yet, Tina. We haven't done a deep dive. But I know someone who is planning on looking at it. But we do have data out of UT Austin for their experience, because they were one of the earliest adopters to switch over to tenecteplase. I mean, to the point where some of us were like, are you sure it's time to do that? Like, we don't quite know if the evidence is there yet. But they switched, and what they found, and are these big enough for you guys to kind of see? Okay, so the big things was, again, workflow that really got affected. And so you can see in the lower one, so door to needles were faster using the tenecteplase, and so this is the same hospital, same patient population, it's just faster to give. You're still going through the same contraindications with patients as to whether or not they meet eligibility. There's no change in that. There's no change in the blood pressure requirements. There's no change in anything else. It's just you're basically swapping one drug out for the other because they're cousins. And the door, I think what's really impressive is the door in, door out for transfers really got shortened. And I think a lot of that is that effect of the bolus without the bolus and drip. that's making it so much easier to get into the hospital, get them treated if they're eligible, and then get them out to the transferring center if something else needs to happen for them. So that's been the UT Austin's experience with switching over. So we don't yet know if our data fully mirrors this, but we'll be looking at it in the near future. So maybe I can come back to you guys with an update about that. Yes?
Ma'am, have you been made aware of any pre-hospital studies on PPA?
So there are ones, but only in the setting of the mobile stroke units. Because you really need to have that imaging to tell you whether they're a hemorrhage or not. Because we used to say if you give it to somebody who's having a hemorrhagic stroke, it's a clean kill. Because you're really going to make them bleed and they're not going to do well. And so that's where you have to have that imaging. And so you can give it in the field, and studies with the mobile stroke units have shown that there's benefit. You're taking, and that's the situation where you're taking the drug essentially to the patient, where there's shorter door to needle times with that. But those units have to have the imaging on board so that they can rule out a hemorrhagic stroke first. We looked into that for the city. There's a lot of politics involved, partly because there's a lot of money. It costs a lot of money to run one of those. And our transport times in the city are short enough. And based on all the other stuff, it didn't really seem like it was going to really benefit in the city to do that, whether or not out in the more suburban, certainly in the rural areas, is probably where that's going to have the highest impact. So out in Virginia, they've really done some good out there because of the longer transport times and getting the mobile stroke unit out there to meet the people in the field. That's where it seems to make more of a difference than in the city, in the more urban areas with a more higher density of the hospitals.
Is there no, I'm going to say, antidote for TPA?
There's really not. There's a bunch of stuff that we throw at patients if they have a hemorrhagic conversion with it. If you go up to real quick in here, it goes through kind of how long it's in your system in terms of active, and it's about an hour post. And so a few patients will bleed within that short period of time, but most patients will kind of tend to bleed more like within the 24 hours. But we still give them platelets and FFP and all of this kind of stuff, trying to sort of give the body back some clotting factors. But there's no randomized trial that's ever looked at how best to do that, because I think people are just, no one really knows what's beneficial and no one really wants to randomize those patients. And so I'm not sure, it's kind of like giving thrombolytics and massive PEs, right? Like you just you give what you got, but it's not a great situation.
So with those comprehensive centers, the big thing is you need to make sure that they have someone on staff 24/7 that can do mechanical thrombectomy. So you need an interventional radiologist to be able to do that, and you want that team pretty much there in-house to be able to do that. And then in addition to that, you want to make sure you have that neurocritical care. And so whether that's a neuro ICU or a neuro designated unit where those patients are going to be going, you also have to have that. And the big thing again is that 24/7 care. So it's not a matter of, oh, they'd be here in an hour, and as you all know, time is brain. We don't have an hour to wait for a team to get there and get a suite ready. They need to be in-house. So that's your big thing with the Comprehensive Stroke Center. So those patients are going to get very quick care, and they're going to get the top level of care that they can, no matter what is going on stroke-wise. Then you have your thrombectomy-capable centers. And so these, they also have that acute team, and they are available to do that thrombectomy. But they have some stroke beds. So it's kind of like they may see lower acuity stroke patients, and they may transfer some of those hemorrhagic stroke patients. Whereas the comprehensive center, again, they can see any type of stroke patient. So they can see ischemic, hemorrhagic, any kind of stroke patient that you can think of. Thrombectomy, they're going to transfer some of them. So just a little bit lower. All right, ER handoff. So a few things that I want to discuss are things that I've gotten from my team that I work with that are stroke coordinators, ER nurses, ICU nurses, different things that they find helpful from you guys bringing in a patient, especially into the ER, things to kind of look out for. And of course, these are all as time permits, right? So definitely that last known normal and onset of symptoms. Patients with facial weakness. So any patient that has any type of speech deficits, slurring, they have a facial droop, anything like that, you're going to be concerned about aspiration. And so another big thing that they wanted me to pass on to you guys is to have that head of bed up. Typically, I see that when I work in the ER, I see people with their head of bed up anyway, unless for some other reason they can't have it up. So you guys usually do that one. Have the patient walk to the stretcher. So this is a big one when you're looking at like posterior stroke symptoms. So you're thinking about that ataxia. Those patients, once they get to the ER and they're in that stretcher, that's it. We're not getting them out of that bed. They're getting slid over to the CAT scan. They're getting slid back over to the stretcher. That's it. They're not even getting in a wheelchair at that point. And so if you guys, when you go pick them up at their house or whatever, if you see how they walk, just make note of how they walk to the stretcher if they're able. If you notice that there's some coordination issues there, they seem dizzy, their legs, things ain't working right, that's something very important to note and tell the nurses, because again, like I said, those patients aren't gonna get up again, and so that is very important information to pass on. EKG, again, these are things that I was told. You guys usually get an EKG whenever you bring in any patient for the most part. IV, so for the IV, some patients, when we're concerned about stroke, they're gonna get a CTA, so a CT angiography. So they need an IV that is at least 4 inches above the wrist, and that's if you're able. When they do this particular test, when they push in that CT dye, it's a lot of pressure, and so it has to be like a really, really good vein. So they can't do hands, so anything 4 inches above the wrist or higher is what they would prefer. You guys usually do an AC, that's literally perfect. If they have an AC that you can hit, literally perfect, but you can at least 4 inches above the wrist. And again, a lot of these things are as you are able. I know everybody don't have veins. Lecanemab, so this is a medication that is fairly new, and it is for patients that have like dementia, Alzheimer's type conditions. And it's supposed to help decrease, and don't quote me on this, like the amyloids that build up from Alzheimer's disease. So it's wonderful and everything. They go in and get these infusions every so often and yada, yada. So the thing with lecanemab is if a patient is on this, it increases their risk of bleeding if they get a thrombolytic. So we've been trying to do like a campaign to make people more aware of this particular medication. And what you guys can do as critical care medics is when you get that list, if you see that the patient is on this, you can even ask them. Patients will usually, well, you're asking a dementia patient, you know how that goes. But hopefully they will be able to know, or they have family that will know that they're going in every couple weeks or so and getting these infusions. And so the big thing, like I said, with this one is if they are on this, they usually will need a recent MRI to make sure they get like these microbleeds. And if you give T and K and they got microbleeds, now you got big bleeds. And so that is the risk with this one. And so it's just important to let the ER doc know, ER team know, if you note that a patient is on this particular medication.
The other thing that would be super helpful is if you see that the patients are in AFib, either on the monitor or on their EKG, if you could double check either with their medications or with their family if they're on warfarin or if they're on L.
Oh, yeah.
Mm-hmm. Because sometimes especially at Barnes, we get patients that we have no record of,
Right.
and we can get labs to test for those. The INR is pretty quick, we get point of care, but for the factor 10A, it takes about 10 to 15 minutes at best to get that level checked, and so we don't want to do it in everybody, and we don't want to hold it if they're not, giving the tenecteplase if they're eligible for it while we're waiting for that, unless we know they're on it. And so one of the invasives said if you see AFib on it, chances are they could be on one of those. So if you would just give a double take question of, are you sure you're not on a blood thinning medication, be really helpful in the handoff to let us know. Even aspirin and Plavix, not a contraindication.